Good morning, and thank you all for joining this morning to our fifth and final webcast on global budgeting for hospital services. This session is going to focus on the federal perspective on the future of global budgeting. I am David Chin, Distinguished Scholar and Director of Executive Education for Value-Based Healthcare at the Johns Hopkins Bloomberg School of Public Health, and I will be your host this morning. Joining me to my left is Patrick Conway, and he is the physician, and he wears multiple hats at CMS. He's currently the acting principal deputy administrator, as well as the deputy administrator for quality and innovation, as well as the chief medical officer at CMS. And he will be talking this morning, sharing his thoughts regarding the federal perspective on global budgeting, as well as the interaction between that and value-based payment in the United States. Before we begin, I'd like to thank the American Hospital Association as well as the Maryland Hospital Association for working with the Johns Hopkins Bloomberg School of Public Health to put this series together. In terms of the format today, as I mentioned before, this is the final webcast. The first one provided an overview of global budgeting and the innovative form of payment in which hospitals are rewarded if they keep inappropriate or preventable admissions out of the hospital instead of being dependent on volume. The second webcast focused on a case example from a hospital in rural Maryland that had a 4-year experience with global budgeting and reinvested some of the savings in some innovative programs that you heard about in the second webcast. The third webcast focused on how global budgeting might work in your particular neighborhood. And the most recent webcast focused on global budgeting across the care continuum. And again, today we'll be focusing on the federal perspective and the future of global budgeting and value-based payment. In terms of the format this morning, Patrick's going to talk for about 30 minutes or so with some slides, and then we will have a Q&A period. And feel free to send your comments or questions to globalbudget@jhu.edu. That's globalbudget at jhu.edu. And they can come in and they'll come here at the iPad, and I'll be able to then send them over to Patrick. So Patrick, I'm looking forward to your remarks this morning. Thank you.
Yeah, thanks for having me. Very excited to be here. Been at CMS now for almost 5 years and leading the Innovation Center for heading towards 3 years. And this is some of the most exciting work we were doing. So really excited to talk about it today. If you go to the first slide, we have a frame for our delivery system reform efforts, which is better, smarter, healthier, specifically better care, smarter spending, healthier people. And overall, in doing this work, we're focused on the incentives, number one, to providers, to patients, so the payment incentives and other incentives in the system. Number two, on care delivery. So how do you integrate population health and behavioral health? This really gets to the global payment methodologies that truly integrate care delivery and the incentives across the system. And then three, information. How do you get the right information at the point of care? Transparent information on quality and cost so the whole system can improve. If you look at the next slide, and I know you've had a number of webinars, so I'll move some of this background material quickly. You know, for us, the Maryland all-payer model was a huge opportunity. Originally, with their Secretary of Health, Dr. Josh Shafson, and John Calmers and others from the Commission, went through a long process to work out the model that you see today. But I think that hard work and the prep work is really paying off with the results that we'll talk about today. And I think critical that we had that partnership with the state and with the hospitals, and then plan to even broaden that partnership more over time in Maryland. As you know, it's an all-payer hospital rate regulation system, shifts hospital revenue into global budgets, and we'll talk about actually Maryland and its hospitals made that shift even quicker than expected, and really can serve as a model for other states interested in all payment systems, and we'll talk a bit about that today as well. On the next slide, you can just see the financial goals for the model. So 5-year model test period. We think it'll generate at least $333 million in Medicare savings over the 5-year performance period, and really measured by comparing Maryland's Medicare per capita total cost growth to the national Medicare per capita total hospital cost growth. There is a limit on annual all-payer per capita spend for hospitals at 3.58% for the 10-year compound annual growth. That's really linked to the 10-year compound annual growth state gross domestic product. And it's shifting virtually all of hospital revenue over the 5-year performance period into global payment models. So a real shift in Maryland. If you go to the next slide, we do focus on all of our innovation center models, lead with quality. So we have a first policy principle that have to meet certain quality goals as part of these alternative payment models where the provider is accountable for quality and total cost of care. So in Maryland, as you can see on readmissions, it was reducing the aggregate Medicare 30-day unadjusted all-cause readmission rate to the national rate. Maryland was above the national rate going into the model, so that's why that was the goal there. And then you can see on hospital acquired conditions, over 5 years, a cumulative reduction on a composite measure of 65 preventable conditions of 30%. And then on population health, Maryland is submitting an annual report demonstrating its performance on population health measures like life expectancy, cardiovascular disease, asthma, other measures of the overall health of the population. On the next slide, further potential and some things to think about going forward in Maryland. One, we think there's huge potential in these statewide rate setting and hospital global budget models. Talking to a number of states right now that have interest in this arena, and we're always open to that. It's important for us to say that to those discussions. It does provide, as you know, fixed, predictable revenue for the hospitals. I can tell you when we talk to hospital CEOs, the ability to have a fixed, predictable revenue and then use that to deploy to care for populations is seen as a huge positive. And it really incentivizes keeping people well and out of the hospital, which is most importantly what all patients and consumers want. If you can stay well, stay out of the hospital, in your home, that is the desire. And incentives to improve operational efficiencies as well. So some things about the original 5-year model in Maryland that we're thinking about as we transition to the next phase or start to think about transition to the next phase is how do you include total cost of care and not just hospital costs. So the model, as you know, includes inpatient, outpatient hospital costs, but not yet total cost of care. So after this first 5-year phase, we're working with Maryland to move to total cost of care, which include physician services and other aspects of total cost of care. And we're monitoring already is there cost shifting outside of the hospital setting to the other settings. So looking at total cost of care already. And then how do you really align incentives, for example, between physicians, clinicians, primary care, outpatient providers, specialist providers with the hospitals, so you're really driving what you want, which is better health outcomes for the population at a lower cost. If you look at the next slide, Maryland is not only on track, but arguably ahead of schedule to meet the goals. So we published this along in the New England Journal of Medicine, so peer-reviewed literature on this study. As you can see, first in terms of savings, after just the first year of the Maryland model, $116 million in savings. So more than a third of the way along the way to the 5-year goal in terms of savings. And most of our models, you actually see less savings in the early years and the savings grow over time. So impressive in this model that you're seeing, this amount of savings in year one. 1.47 in all payer total per capita cost growth. Obviously if our nation grew at 1.47, we'd be in a much better financial place as a nation. And the 30-day readmission rate did get reduced. So still more work to do, but trending in the right direction. And you can see a 26% reduction in those preventable complication rates. So significant progress in year one. And as I said, we published this in the New England Journal. And importantly, by July 1st of 2014, hospitals had agreed to move more than 90% of the state's aggregate hospital revenue into global budgets. So this is actually ahead of schedule. I'll tell you a story that you may have heard, a similar one in one of the previous webinars, but really struck me. Hospital CEOs that said, we thought about going slower. We thought about making the transition slower. But at the end of the day, we knew if we were going to move into a population-based payment model, that we probably need to do that quicker. We couldn't have a foot in each boat, or whatever analogy you want to use. And we really needed to change the way our care delivery model and our financial model. And it actually, we thought, was smarter to do that quicker and move at a more accelerated pace to achieve the goals. And I really think because the hospitals moved at a much more accelerated pace, I believe, in my hypothesis, that's why you saw the results that you saw. So it's on some level, it's about cultural commitment to care delivery and then executing on that cultural commitment. This next slide, I did just want to share the high-level frame. This is from a JAMA paper we published as we think, how does Maryland fit in the broad payment landscape for CMS? And I should say this categorization scheme through our Healthcare Payment and Learning in Action Network is being modified slightly, but very similar across private payers. So we have a network now of private payers and others that are setting goals for alternative payment models and population-based payment and reporting on those goals. Category 1 is fee-for-service with no link to quality or cost, really moving away from that. Category 2 is fee-for-service with a value or quality link, so things like hospital value-based purchasing where you're adjusting payments up or down. Category 3 is alternative payment models like accountable care organizations or bundled payments, still being built on a fee-for-service architecture. They can be one or two-sided risk, but really moving to, this is the first alternative payment model category where the provider is accountable for quality and total cost of care. Then population-based payment, Maryland's one of our few models that is true category 4, which is, payment for a population. And we think, that is the sweet spot, if you will, in many instances that will drive the maximal positive change. That being said, we recognize providers, states, communities are at different places, so we have to meet them where they are and sort of move along the trajectory, but we're excited that Maryland moved this quickly. The last thing I'll say on this slide is, for the first time in history, the President and the Secretary of Health and Human Services made a very specific goal for payment in this country for Medicare, that we would have at least 30% of payments in category 3 and 4 by the end of 2016 in alternative payment models, and 50% by the end of 2018. We were at 0% in 2011, 20% in 2014, and we're on pace. I think we're going to reach that goal of the 30%, and hopefully ahead of schedule.
Terrific.
And as I said, other private payers are matching that goals in other states. So, it's very exciting, a state like Maryland, moving in this direction, helping us achieve those goals. If you go, and this is my last slide, so we will finish with plenty of time for questions and discussion, so hopefully there'll be a lot of them.
It should be.
What are some lessons for states considering global budget models? I think a few lessons and considerations both from the slide, and then I'll add a few more. I do think state-based global budget setting authority or a similar mechanism to set up the payment model. Maryland has some unique attributes that may not be completely generalizable or transferable to another state, but I think there's principles that other states can learn from about global budget setting and then thinking about how they apply those in their state. And obviously the Health Services Cost Review Commission here plays a critical, important role. Transparency in the process of setting budgets. So for this to work, the state, the federal government, and the providers and payers and others in the market need to understand, how are these arrangements set up, at least at a high level. Strong political leadership. I mentioned Secretary Josh Shafton when he was in Maryland, and the governor, really committed to this transformation and shepherding a complex set of issues. So I think, when we look for state partners, we look for that kind of strong political leadership and commitment. And we continue to work with the political leadership in Maryland today. And so that partnership is critically important. And collaboration across stakeholders, I can't say how important this is. You need all the payers at the table, the providers, the consumer groups and patient groups, large employers, really focused on working on this transformation together. If you're missing some of those pieces, it's much more challenging to be successful. I will say here we've got a few states looking at making these transitions, and once again we're open to those discussions. So Vermont has talked publicly about their all-payer ACO concept and moving to population-based payments, and we are working with Vermont on that and in discussions. We have other states that have come in with global payment models for rural hospitals, which we think is a really interesting area to look at. We know in this country rural hospitals and critical access hospitals have major issues in terms of financial stability. And so the question that this state came in with was, we want the provision of care in these communities, but we want to think about what that care looks like, and we want these hospitals to become much more population health entities that are supporting their community as opposed to more traditional hospitals. And we think that's incredibly exciting, and we have a deep commitment to rural health care at CMS. So very excited for states that want to think about all the hospitals in their state or all the providers in their state in global payment models, or segments such as rural hospitals. The last thing I'll say about Maryland, just to hit on again, we're excited about the next phase. So we're already starting discussions with Maryland about, once the 5-year hospital global budget is up, the goal is to move to total cost of care across all providers. And we're trying to think about what are some interim steps that might be possible along the way, such as primary care transformation, primary care medical homes, those type of arrangements, and really thinking about that physician and clinician alignment, that outpatient alignment with the hospital as well. So we're already starting that work. So I'll end where I started. I want to thank you for having me. I want to thank the state of Maryland and all the people who helped set up this model and all the providers in Maryland to make this commitment to transformation. I think, as you see, really exciting results, and we look forward to the future.
Thanks very much, Patrick. It's exciting stuff, and glad to hear about the progress.
Yeah,
I'd
terrific.
like to have your thoughts. Some questions are coming in about macro. There's a big thing that occurred this past spring.
Yep.
that supposedly aligns physician compensation towards value-based payment. Can you talk a little bit, give the audience a little background about that and how this might work with Maryland?
Yeah, I will. So MACRA, as you said, was the fix to the sustainable growth rate. And they did two important things. Lots of other parts of the legislation, but we'll call out two important things. Number one, we had many physician and value programs, and they said that were separate. So you had a physician quality reporting system, a meaningful use system, a physician value modifier. So you had all these you had all these systems that we had aligned on the back end, so you could report once, and then we would calculate your incentive for all the programs. But didn't make a lot of sense to physicians and clinicians because seemed like different programs that they didn't totally understand. So they established in MACRA what's called the Merit-Based Incentive Program, which takes all those and makes it one program. Physicians that aren't in alternative payment models, and we'll come back to that, have a single reporting mechanism on quality, resource use, clinical practice improvement, and use of electronic health records, and we'll have a score produced from that. It's a budget neutral program. Some will get more payment, some will get less. The second critical component, which we think is incredibly important and relevant, particularly to the Maryland example, is 5% incentive for physicians or clinicians in alternative payment models. The statute did talk about more than nominal risk, so it's at a higher sort of towards, if you will, the potential for two-sided risk model. But a 5% incentive is significant to physicians and clinicians. It also in future years has a higher update in terms of their payments, so real incentive. And I think the work we're doing now, we put out a request for information, got a lot of impact from physicians and clinicians about, what should the various specialty models be? What should the various primary care models be? How do we set up a construct that physicians have options in terms of alternative payment models? And I think for Maryland, what you'll see, like in many states, is the physicians and clinician community is very focused now on how can I become an alternative payment model, which we think is a good thing. I should say we don't think out of the gate every physician in America will be in an alternative payment model because people are at different stages. My sister's a solo practitioner physician in Cincinnati, so she'll have to think about who she works with to sort of go along that trajectory. But we're really excited that the incentive structure and the statutory framework points towards population health management, which is very exciting.
And I think I've heard that CMS has set some targets in terms of value-based payment for physicians, so which is different than these value-based payments, the global budget for Maryland.
It's interesting. We sort of roll our targets down. So we have the high level 30% alternative payment models, 50% by 30% by 2016, 50% by 2018. And then we have value-based targets, which is 85% with a tie to quality and value by end of 2016 and 90% by the end of 2018. So almost no payments that are just true traditional fee-for-service left. That category one, going as close to zero as possible. And I think we're on target to meet those goals. And then we monitor those across settings. So in the physician space, we'd like the physician setting to meet those goals as well as the overall goal. And even at the state level, we work with states. When we negotiate waivers now, we have discussions with states around these are the goals. Could you match these goals in terms of your state programs, both Medicaid, if they have their employer-sponsored programs at the state level as well. So it's really how do you align all those incentives and pieces in place so in a state or a community, the goals are clear and we're moving towards achieving those goals.
Terrific. Now, by definition, the 49 other states are not where Maryland is right now.
Yep.
So if you were to give advice to hospital leaders and physician
Yeah.
groups out there, how to get started? Where do you start? Because it sounds very, very complicated.
Yeah, and I think it will vary. The first thing I would acknowledge is, if I've learned anything in this job, the 50 states are very different. So the solution, and that's one of the beauties.
Yeah,
of
that's
it.
part of the genius of the American political system.
And so I think the solution will look different for various states. Let me give one background point and then directly in.
Yeah.
So we're doing state innovation work, which is states are either testing or designing, and we're working with 37 states and territories.
Okay.
And what I've learned from that is there's common themes like accountable care organizations, bundled payments, primary care medical homes, and a few states looking at global budgets like Maryland that sort of traverse across. But then often states will have their own unique issues. So a rural state like Idaho, which is one of our models, very focused on rural issues, telehealth issues, telemedicine, because that's critical for their population. So we acknowledge, the sort of solution for different states will look different. What I'd say for any state looking at this is first, make sure you have that coalition of the state leadership, the provider leadership, and the payer leadership, and as much as you can, consumer and patients and employers at the table. Two, determine your ideal state, sort of where you want to get to eventually, and think about the goals around that. And then three, and this is really where the hard work comes in, figure out what's the pathway to get there. Mm-hmm. So, we have, as I said, I mentioned the state looking at the rural hospitals. We have another state looking at their sort of critical access in rural hospitals in a different way, sort of a slower transition to global payments. We CMS are open to those discussions. I mean, if it's aligned with our goals, which I laid out of better care, smarter spending, healthier people, we actually can be fairly creative. Sorry, it's a longer answer than I meant to, but what we also tell states is they sometimes come in and say, I want a waiver. And we often say, okay, what do you want to do?
Yeah. What do you
Tell
want
us
to
what you want to do and where you want to get to, and then we can figure out, which regulation or waiver, et cetera. We can figure out the pathway, but I think really the critical path issue is for the state and the various stakeholders in the state to identify, where they want to go, what do they want to do, and what are the first steps along that pathway.
You mentioned two things. Maybe you can share with the audience.
Yeah.
One is around a learning network.
Yep.
And could you share with them how, if they want to participate in this, how to do that? And then the second is around the state innovation model. So some interesting things are coming out of that.
So I'll answer three things back. So
Okay.
One, all of our models at the Innovation Center, which is different than traditional CMS demonstrations, have a learning collaborative network component.
Okay.
So whether it's ACOs or comprehensive primary care, and this isn't CMS teaching the providers, this is people in the model teaching the other people in the model, or experts teaching the model. So our comprehensive primary care model will have various practices teach other practices how to be successful, or we'll think about how various technologies can be used. Our state innovation model has a learning system. So the various states are learning from each other. And those 37 states and territories are learning, what worked in your state. Oh, you did bundled payment for, we had a state that did bundled payment for the mother and the child in Medicaid.
For what services? Total?
For the whole, so they did bundle from essentially, and there's good evidence that investments in prenatal care can decrease perinatal complications, cost, better out. So essentially investing in the sort of prenatal and perinatal care, but thinking about it as a whole bundle. Like really creative, right? Some other states thinking about, maybe I could do that. How would I do that? So that learning system is critical. The last thing I'll name for all states, because some states are going to say, well, I'm not in the state innovation model. What do I do? We launched a program that we call Medicaid Innovation Accelerator. Its door in, if you will, is Medicaid, but it's sort of broadly applicable in states where we're supporting states with things like payment model development, data and analytics, quality measures, and that's open to any state. And so I think if states are looking to transform their health system, we have multiple mechanisms to meet them where they are.
That's real helpful. And if there are people out there who are listening, can they access these learning networks directly, or is it you have to be part of the club, so to speak?
It's a good question. So let me try to answer it. It depends is the short answer.
Depends, okay.
So then the ones that are solely focused on a model, so there's a state innovation model network. It is those 37 states that are in the learning network. But we have some that are fully open. So our healthcare payment and learning and action network is a totally open network. We've got 8 of the 10 largest private payers in the country. We've got over 25 states engaged. We've got large employers. We've got over 1,000 provider organizations. So there's some that are totally open. We're about to launch an initiative called Transforming Clinical Practice, where we've already selected the initial organizations, but they're out recruiting physicians and clinicians right now. This is an investment
Across the country?
Across the country. Yeah, we actually have one in every state. Or, there may be one that covers multiple states, but we cover the entire nation. They're recruiting right now, and the whole point of this, it's over a $650 million investment focused on outpatient physicians and clinicians saying, we think we need to support you in your transformation efforts. So this is, we're funding organizations they may be national, they may be state, they may be community-based, but have some of them are even specialty societies that are going to work with physicians and clinicians to improve quality and lower costs, go through 5 stages of transformation from sort of the beginnings of setting aims to like the end state being, high-functioning population health management. So would encourage, and that's on our website, Transforming Clinical Practice Initiative on the CMS Innovation Center website.
I was just going to say, give you the plug and let people here know.
They're recruiting right now. So
give that information again.
Transforming Clinical Practice Initiative on the CMS Innovation Center website. There should be a big button. If there's not, you guys can tell me afterwards. But our goal was to have over 140,000 physicians and clinicians in. It's just ramping up now. The official launch date is January 1st, and we already have over 35,000 physicians and clinicians signed up. So sort of in the pre-launch phase. So really exciting time for transformation.
And there's funding from CMS to help accelerate that.
Exactly.
As well as I assume there's a learning network.
With that will be a robust. This is actually. We did Partnership for Patients work today, we didn't talk about in inpatient hospital safety. There was a big learning network that was successful. I will give you the numbers, sorry. 17% reduction in harm, approximately 87,000 lives saved so far, over 2 million injuries, adverse events, infections avoided, and $20 billion in cost savings. It was a similar sized investment and we're working with 80% of hospitals. This is over $650 million to try to work with over 140,000 physicians and clinicians with the goal that, 4 years from now, we'll have similar results in the outpatient setting, demonstrating, better quality, lower cost, because we made this investment.
Now, you had mentioned in terms of, again, the theme of trying to get started, so it sounds like this is a way of getting started for physician groups.
It is.
And then you mentioned some states are looking at a rural kind of setting. So I'm just listening to you, it sounds like in a rural area, you might be able to get that kind of coalition that you're talking about of payer, employer, provider, consumers together. Has that been the experience?
Not surprisingly, there's some variability, but we are seeing communities, both rural and urban, that bring those stakeholders together. And that is, I'll give you some examples.
I was going to say, your Liberty Shared,
I'll give you some examples.
Urban and rural.
I'll give, I'm trying to think of the best rural example. I'll give you some rural and urban examples. So Akron and Rochester, so sort of mid-sized cities, if you will, have some really robust, interactions across Hennepin County, which is a mix of really linking the social determinants of health and public health infrastructure with the clinical care delivery system. We actually learned so much from that. We're going to be announcing very soon a model we call accountable health communities, where we're basically saying, you've got some of these communities that are starting on their own, sometimes employer-sponsored, sometimes county-sponsored. We, the Innovation Center, are going to put in money into accountable health communities because we think it can be a catalytic investment. So we'll put money forward and say, we want your community to think about bringing the stakeholders together, linking the public health and the social determinants of health and that infrastructure with the clinical care delivery system. Also thinking about the long-term financial model for that, but we'll put the upfront funding in place to drive better health outcomes and lower cost at a community. And our goal would be these would be a mix, so urban, suburban, and rural. to test it in different environments. The rural, we've got some rural Arkansas examples as part of our SIM grant as an example, but I think we need more of the rural examples as well, because obviously what works in a rural area may or may not be the same as what works in an urban area.
Well, you hit upon a particular area that's important in terms of accountable care communities. I think from a public health perspective, everyone, I've certainly learned growing up in the acute care model, population health, public health is a different animal.
Yep.
And the focus on the 95% of the time that patients spend outside the delivery system.
Yep.
So could you say more about where CMS is headed?
yeah, that's a good question. I actually wrote a paper about CMS's role in population health.
Okay.
3 or so years ago.
And where was that published?
It was either JAM or New England Journal of Medicine. That's going to be embarrassing for one of the two. I apologize. One of their editors is now mad at me. So I think, anyway. But a great journal. They're both great journals.
Good recovery.
Yeah. When I started that work, and then I'll tie it to accountable communities, there were people that said, why is CMS talking about this? That's CDC's role or somebody else's role. I fundamentally don't think that's true. So CMS is, the largest payer in the U.S. by far. We spend over $1 trillion a year, over $2.5 billion a day. The fundamental question we have to ask ourselves is how do we foster an environment that those dollars are the most well spent and effective as possible? Accountable health communities from the Innovation Center, our hypothesis will be that by making those community investments and building those linkages, you'll actually lower health care cost. And we pay a significant proportion of those health care costs.
Yeah.
And so, this is it's a model test like any of our model tests. The goal is to test in those that improve quality and lower cost. We expand, like Pioneer ACO was one that was successful, and now we've expanded we put it as a permanent part of the Medicare program and our Medicare Shared Savings Program, Track 3. Accountable health communities we'd be testing, and if successful, we think about what are the mechanisms to expand.
Now, taking a slightly different cut on it, I know we have questions out there about, if I'm looking at this from a specialty point of view, like oncology services, how might one get started with that?
So oncology, two major ways. One, we actually have an oncology care model where the applications are closed right now, but they could be opened up again. That is, oncologists can participate in it's basically an episode-based payment model in oncology. So, responsible for episodes of care for cancer care, and if you can improve quality and lower costs, then they can share in those savings or even move into a two-sided risk model. Broadly, I think for specialists, we have a number of models available for specialists, but I think this is an area to go back to MACRA. They put out a framework with an advisory committee, some funding, and calling on specialty societies and others to come forward with alternative payment models. I think the next few years, are a critical period where, if we're successful, and you could pick the date, 3 years from now or whenever you think the right date is, you'd have a multitude of specialty models that are alternative payment models. So you have pathways for cardiologists, oncologists, et cetera, as well as multi-specialty groups. And we're not there yet. The reality is, if and this is true for CMS, it's also true for private payers. For cancer care, there are some alternative payment models, but when you go into some of the more subspecialties and super subspecialties, we don't quite have the right alternative payment model yet. So we're going to have some work to do, partnering with physicians and clinicians.
With them directly, or with the specialty societies, or all of the above?
Probably all of the above. A lot of our work is with the national organizations, and they bring in the individual physicians and clinicians. I'd also say we've done things like Healthcare Innovation Awards, where we may fund, a specialty model in New Mexico that actually helped inform our oncology model. So it was sort of initial work with a smaller group of physicians, sort of test on a very small scale, almost like a prototype, and then it becomes a larger model for larger numbers of physicians and clinicians.
Now, another set of stakeholders are safety net hospitals. I mean, they're a mix of rural and urban, and so can you say more how a safety net hospital might get into this sphere?
So, first of all, it's an area that I and CMS worry about a lot. So, I mean, we worry about vulnerable populations and the providers who take care of those populations. So, I think in safety net hospitals, I do think there's still an opportunity in the global budgeting and population health management arena. Many of those hospitals and health systems have tight linkages to their community and their patient groups. And so I think our collective job, both the safety net hospitals and CMS, is, what's the payment model and what's the transition period. So for many of these hospitals, they may have challenging financial margins. So, it may be challenging to take up a large amount of risk, for example. And we're open to that. So, in the models I've described, we'll often realize that, in the early years of a model, we even may need to make an investment or have very small amount of savings for CMS. But the idea is you're building the infrastructure and the capacity to be successful in the later years of the model. So I think, we're very open to think, in all our models, we think about how it affects the safety net, and we're also open to models that are, directly aimed at safety net institutions.
I know there are some, very large systems across the country, safety net ones. Hennepin, I think, has a safety net, and LA County, Cook County.
Denver Health.
Denver, New York. Any models emerging about Grady, merging
Yeah.
with those kinds of hospitals that might be helpful for the audience?
Yeah, I mean, a few to mention. So Denver Health was one of our innovation awards and has done
Okay.
some really interesting work that on, lean process improvement and sort of population health management and integrating all services. So and I think that's one example. We talked about Hennepin, which also we have a relationship with. I think our question now is how do you scale some of those models? So I think you see pockets of success in the safety net, but the question is, what components or in totality of that can be scaled to other institutions? Because we also see safety net institutions in our data that aren't having that level of success. So how do you spread that success across the safety net, if you will?
Any themes that emerge from the ones that have?
Yeah, I'd say a couple. So I think one, operational efficiency.
So the lean.
Denver's, a bunch of their work, honestly, and I'll come back to other work they did, but Denver Health, I mean, it was a tradition of lean that was, I've been out there, and originally by Patty Gabeau, their CEO, and now carried on, that is, deep ingrained part of the culture. Two, I think it's true population health management. So think about the whole population they care for, not just the patient in front of them, but all the patients that may not be coming through their doors. And that gets to data and analytics and what you do to manage populations. I think the third is this tight linkage to the community in every sense of the word. So social services and public health parts of the community, physicians and clinicians in the community that aren't part of your system, the nursing homes and the sort of referral networks, and thinking about who do I partner with and what does that look like. I'm jumping now, but our bundles payment model, we literally have hospitals that say, I never interacted with the nursing homes that we referred to, hospitals or physicians, which is obviously not what any patient would want to hear. That you're getting discharged and the hospital and the physician have no idea like what happens next. So I think a number of these models have that theme of like how can you be patient centered and think about that patient across the lifespan, across the episodes of care.
So how does one get started? You mentioned here at Maryland we have the global budget for the hospitals. Yet to move into physicians, but now you mentioned it exactly right. SNFs, home health facilities, home health care. How does that all get bundled in?
What I would ask, if I were on the other side, and I would say for any provider, but let's stick with hospitals for now, like a hospital CEO. I'd look at the array of options, of which we have many, and think about where might I get started, and then let me sort of give some more texture to that. For many hospitals, they may start in what's called our Medicare Shared Savings Program, Track 1, because it's one-sided risk. There's no financial risk. And if you haven't managed populations, previously, that is a easy step, relatively easy stepping stone. We give you data, we give you information. If you generate savings and you meet quality targets, you share in those savings. But if you don't write us a check at the end of the year because it's one-sided risk. So I think that's a good example of sort of a starting stepping stone along the path. We have, now over 400 ACOs. On some level, I'm amazed we don't have even more in Track 1. I mean, it's one-sided risk. You actually cannot lose.
It's really not risk.
You can only lose your investment. Some of them will say, but I have to invest, which is true. I think to do the transformation, you will have to invest. So you will have to make some investments to be successful. But from a financial standpoint, you're not going to lose at the end of the year. And then I think people build over time. We now see from the Track 1 ACOs, a number of them saying, well, I now want to go to Track 3, which is two-sided risk and prospective attribution, because I'm ready to really manage that population. Or our farthest end accountable care organization program is called Next Generation. We're about to announce the first cohort, and that's full risk. They're saying, I'm going to be accountable for
Everything.
almost like a
Hospital.
health plan, but you're a provider. I'm accountable for total cost of care. We give them a target, which we just did. They're all determining whether to sign their agreements right now. And we say, here's your population, here's the payment target, here's the quality measures. We hope you sign up and manage this population. And it's a deep partnership. I mean, we want them to be successful. I mean, waivers like SNF waivers, telehealth waivers and how they interact with the beneficiary, dollars going back to the beneficiary if they stay in network. So, we think point being there's an array of models. Every organization's got to assess where they are on that sort of risk continuum and population health management capability. And then there's some that aren't ready at all to enter one of these. And there you think about transforming clinical practice or initial investments that say, I've got a brother-in-law that's in a 20-doc GI practice, my sister's husband. And they actually want to move into this world, but they're not sure how.
Yeah.
I don't know if he applies. I will not review his application. I have no idea if he's even going to apply. But that type of practice, it's it would be a perfect type of practice. 20 physician clinician practice for transforming clinical practice to say, I want to start thinking about data and quality measurement and how I improve over time. I will not cite my brother-in-law's practice again. I apologize, Kim. But his practice, I'm sure, is incredibly high performing. But generally, we're trying to support people across the whole continuum.
In terms of the global budget, how might it work for Safety Net Hospital?
Yeah.
So I'm LA County or something like that, some big entity. It would seem like they have some infrastructure, but how do you get started in something like this?
Yeah, so I think it's a great question. I think it depends a little bit about where they want to start. But if they want to do, let's stick with healthcare spend. I mean, we would do similar to what we've done in Maryland and other places. We would say, let's figure out the attributed population. Let's figure out the historical cost for that population. Let's trend what we think the trend would be, and then on the cost side, essentially, some savings on the Medicare side. I will say, there were people in our system that wanted the Medicare model to have a target of, billions of savings. And there were other people, including myself, who said, let's target reasonable, achievable savings. And they may exceed that. But you don't want to set the target so high that it's like, if you're the provider, it feels like a ton of risk suddenly being hoisted on your back, if you will. So, we have some... with accountable health communities, you get into some interesting issues which we haven't totally figured out of braid funding. Could you set a target?
Of what kind of funding?
Braid funding. So could you set a target? So some of these systems have both healthcare costs plus social and public health service costs.
Okay.
This gets really complex with the state, the county, and the community. That's the braid. But you could make an argument that we should care about health system costs, which are healthcare costs plus public health, social determinants of care, et cetera, costs. And even though, and this is where it gets challenging, we've got federal streams, state streams, communities in many states, like different departments.
Not-for-profit stream,
Not-for-profit. But I think accountable health communities, when we come out with that, we do bring out this concept that we are open to thinking about braid funding and other more complex funding arrangements to think about savings for the whole health system as opposed to just the healthcare system. We do have statutory mandate, I should say, so I don't get myself in trouble. All of our models have to have some savings on the healthcare side because that's our statutory mandate. But we also are allowed to measure on the whole health side, if you will.
Now, any places that sounds pretty innovative in terms of across the continuum of care, braid funding. That's a new term I just learned today. So any lessons there you could share with the audience about?
Yeah, I mean, you should have Josh and some of the other folks probably talk to this one. They probably teach me a few things. But, the main thing I'd say, a lot of this is very early stage.
Okay.
It's not like there may be one that exists that I'm not aware of, but I can't point to a state or community that I say, I think this is the ideal end state for braid funding. I think we have had a few, places like Hennepin County and others have thought about these concepts and are starting to apply some of them. I think as a nation, we'll have to think about, how do we tackle this issue of different funding streams and how you would bring them together. And if you generate savings, how do you distribute those savings back to the various entities?
Well, maybe it might be helpful. I recognize this early, so you wouldn't have the actual model. But I suspect some of the folks in the audience might be curious about how you even start the weave of the braid. How do you get that started?
So I think the easiest, one of the ways one could start the braid would be in some of these communities, essentially healthcare entities, hospitals have gone into more ACO type contracts.
Okay.
And then when they're responsible for the population, they want to decrease healthcare costs, and they partner with community-based organizations, public health organizations. And in those partnerships, the hospitals and health systems may be transferring dollars into the community and the other support systems. And then the goal is it becomes a self-fulfilling wheel, if you will. Those investments help bring down healthcare costs anymore. The healthcare delivery organizations have contracts with payers that return an investment on that return, and they can reinvest in social services. I will say too, to name another example that I've named before, but actually I'll name two if it's okay.
Sure, absolutely.
One I haven't named before, but I was just there. The one I have named before is Montefiore, where they're in our Pioneer ACO and looking at next generation ACO now, so more at full risk. They built temporary housing. So they said, we've got a very high cost homeless population that is hurting us in this contract from a financial standpoint, and we care about. They tried to solve it with the community, had struggles, invested in temporary housing, that they put homeless people into that temporary housing, get them back on their feet, and they can show a return on investment with, based on decreasing of healthcare costs for that population.
Wow.
They've got a care coordination team that is now more than 1,000 people, including mental health, behavioral health, social supports. So I think you can do complex braid funding. You also, some of these contracts, the very sophisticated organizations can build the infrastructure to provide that diverse array of supports. I was just at Emblem Health. This is one I haven't named. Emblem Health.
Also, both in New York. He's
both in New York.
You can make it in New York.
There's non-New York examples too, but Emblem has these public health, social service clinics where it's like walk in and they serve the whole community, but a significant number of the community is in their health plan and seen by their affiliated physician organization, which takes on risk. And they basically said, we're doing this because one, it helps the community, but two, we can actually show the return. When we solve food insecurity and food-related issues around diabetes or hypertension, we see a return in our population. Plus, it helps people in the community that aren't in our population, but we're a community. That's our community service for the ones not in our population, and for the ones in our population, we can actually show the return. But really interesting models that are, literally, I was there, and there's patients in physical education classes on one side and diet classes and transport and education oriented services right next to the physician offices of Emblem Health, right next to the payer offices. So,
that's impressive. And free, so it's free to open to the community.
The majority of the services were free.
Amazing.
And all of them are open to the community, and the majority were free.
Wow.
So really innovative models.
And that's across all of Emblem?
Yes, it's you'll have to double check if it's everywhere they are. But they have well, I should say they have these centers set up around. So they don't have a center in every part of their entire catchment area, but they're increasing. They have a significant number now and are increasing over time.
That sounds a fascinating case. I know the audience is principally of hospitals.
Yeah.
But how did thoughts in terms of how payers get into it? Because Emblem really is kind of a blend between a payer and a provider.
Yeah, I mean, so that's a fair point.
Yeah.
Some hospitals are blends of
Sure.
hospitals and payers,
Yeah,
but
that's right.
If you don't have the payer angle, I think it's how do you go into a contract or in a relationship. And actually, I would say this is the key point. If done well, it's a true relationship, including for CMS. It's a long-term goal, not a what's my return next quarter. So what are the payers in your area? Which ones could be good partners to have these type of relationships? And I think if done well as well, the payer has to support the transformation with everything from data to analytics to information that helps the provider be successful.
Well, information is a good segue. All the hospitals, because of the Stimulus Act, et cetera, and meaningful use, have made major investments in EMRs.
Yes.
So going forward, now that we've got these EMRs in these hospitals, what do we do with them to take advantage of what CMS is trying to do going forward?
Yeah. I think the good news about the healthcare and EHR incentive program is, significant uptake of EHRs across hospitals. And, we have over 98% of hospitals have received an incentive, and over 70% actually of physicians and clinicians have received an incentive payment. Yeah, I think our next challenge, which gets to this question, is the interoperability and data movement issue, which we tried to do a number of things of stage 3 in terms of mandating more standards, really focusing on things like application program interfaces, which are like open data interfaces to make sure the data can move. I'm going to be practicing in the hospital this weekend. I have the joy of practicing in a hospital that's linked to the other major pediatric hospitals in the area, so I can get information from my hospital plus others. That's not true in all environments. So we still have instances that I hear about a lot of, my EHR works for me, but I can't communicate down to the hospital down the street. I think, the ideal state here that we need to push for, and we're trying to push hard on, is how do you have the standards and the infrastructure so data is truly moving. So, and without that, you don't capture the whole value of the EHRs. So I think the organizations we see that are successful as hospitals have an infrastructure sometimes that sits on top of the EHR. That is, patient registries, population health management tools, applications that help the EHR data be most useful to their physicians, clinicians, and care managers. And I think you're going to see more and more of that. You may have a core EHR vendor, but you may have other entities and partners that have built applications and tools that sit on top of the EHR and help you manage your population.
And building on that, you mentioned before at the outset that the key thing was having a population, focused on population health for the global budget.
Yeah.
And so one of the keys is attribution.
Yes.
So in a place, I'm curious, in a place like New York or Montefiore, particularly with the homeless, I'm trying to think how do you deal with attribution in a population like that?
Yeah, there's almost like this is not going to be a super easy answer, but I'll try
Okay,
because it gets complex. But it varies by the model. So let me answer that one, and then and we can talk brief. Maryland, you probably got a lot of detail on, so I won't go into the detail. But there we prospectively identify their population based on who's been in their system in the previous year, and then we add to it if people come into their system. And now we have it used to all be claims attribution.
Okay.
Now we have a key change that at the point of care, a doctor or a clinician can have a discussion with the beneficiary and say, do you want to be part of this ACO, essentially. And the physician the beneficiary, the patient, can make an active choice. I'm part of this ACO because I'm going to get these care management services, which makes sense to me. That was a huge step forward, I think. We call it voluntary alignment. But from a beneficiary standpoint, I think now you're making a proactive choice. It's not just I'm in some claims attribution I don't understand, and I suddenly got a care manager, which is interesting and I like, but I don't really know why.
Yeah, I've opted in,
which happened to my own mother. But the proactive choice, I think there's benefits in that then the provider knows that they're managing you and will deploy resources to help partner with you and manage the patient. I also think there's something my hypothesis, there's something psychological as well. As a patient, you said Montefiore is my provider, or Denver Health, or whoever the provider is, this hospital and its affiliated physicians. I think my hypothesis, there's also something almost psychological or behavioral economics around that, or behavioral around that. That is, you're making a commitment as a patient. So that's sort of a high level in attribution. Maryland has, then we have other models that are a mix of geographic based plus, patients through the system attribution. I do think it's critical as a provider, we tell our teams this, it's got to be understandable. So our attribution methods can't be so complex that providers can't figure out who's in and out of their population. And generally we've heard prospective attribution better than retrospective. Tell me my population and my target ahead of time, because then I know the goals, as opposed to, at the end of the year, you tell me how I did and tell me who was in my population.
Now, in terms of that's one of the challenges of global budgets. I recall from some of the literature, Medicare beneficiaries tend to cross delivery system lines.
They do some.
And so,
Yep.
how do you deal with that in the context of a global budget?
Yeah, we have a complex way of setting the global budget and then have essentially reconciliations or true-ups depending on the overall rate of movement.
Yeah.
That's sort of the short, high-level version, a lot of detail underneath that. I also think, providers also often use the word stickiness. I'm not sure if I would use the word engagement. I think increasingly we as a nation need to work on true patient engagement and driving care goals and sort of real patient at the center, which will keep patients if you build that relationship, I think they're much more likely to stay within your network as opposed to seek care elsewhere. And it gets everything from strong primary care relationships to other aspects that, they see the value of being in your network. I mean, some of the ACOs I mentioned, their patients are like, my provider is X. It's my doctor, my provider. I see them for everything. I would never go outside because, we have a relationship. They know me. And that's the kind of engagement I think you need to be more successful in these kind of models.
We only have a couple minutes left, but maybe end with we talked before we started about the need now going to value, about patient-reported outcomes and getting their input around value. So this might be a good segue into how does CMS approach this whole issue of getting the patients involved from a measurement perspective?
Yeah, so we're increasingly using patient-reported outcomes. So a tangible example, we just announced a joint model where one of the quality measures is patient-reported outcome on functional status after hip and knee replacement. So I think you're going to see more and more of this. I mean, on some level, it is the ultimate outcome. What is that patient-reported outcome of care?
Sure.
When I was at Cincinnati Children's, we could actually measure patient preferences of goals of care and then measure how well we achieve them. I haven't figured out how to do that as a nation yet. But ultimately, that's almost the ultimate patient-centered goal. I have multiple chronic conditions. I think, I want to be able to garden and do this and that, and then you sort of measure attainment of the various goals. So I think we're not quite there as a nation yet, but where we are is increasingly we have quality measures that are directly patient-measured, reported outcomes, and I think you're going to see more and more of that over time.
Well, it looks like we're just about running out of time here. I want to thank you, Patrick, for joining us this morning. This concludes our final webcast on global budgeting, and please join me in thanking Patrick for a very informative session. I think we're all in store for some exciting developments over the next few years as the whole nation, under Patrick's leadership and CMS's leadership, move towards value-based purchasing and achieving the triple aim. So again, thank you very much for joining us this morning. If you have any further questions or comments, please send them to the globalbudget@jhu.edu. And also, this webcast and the other webcasts that I referenced are all archived. So if you want to go back and listen, please feel free to do so. And happy holidays. Thanks very much.